Yeah, I think we are live.
Hello.
Good evening, guys. Good evening, guys. Welcome to the session. I think we'll be started. If you guys can hear and see us.
Hello, guys. Can you see us? Can
Good
you
evening,
hear us?
guys. Welcome to the session. I think we'll be started. If you guys can hear and see us.
Hello, guys. Can you see us?
Good evening, guys. Welcome to the session. I think can hear and see us.
Hello, guys. Can you see us?
Good evening, guys. Welcome to the session.
No. Hello, guys. Can you hear me? I hope it's not echoing again. Yeah. Am I audible? Is it echoing? Is Dilip audible as well?
I'm just speaking here because I couldn't close the tab because I need to have visual of you. That's why.
Okay.
I think, are you able to see Ranjith?
Yeah, I can see you. I can hear you without an echo, hopefully.
Yeah, even I can see you without an echo. I think better now. Okay. All set. Cool. Let us move on. I think we can start the session by now.
Okay. Can you guys
Students
you just read them a question and give an appropriate answer. We'll take a go from that.
Yes, I think it's Ranjith's question. It's purely pathology, and Ranjith will be discussing and answering that in a while.
Okay, what's the answer here? It's a 60-year-old male with no significant medical history. Evaluation of one CBC count shows a platelet of 76,000 and hemoglobin of 9 gram percentage. Peripheral smear shows mononuclear circumferential hair-like cytoplasmic projections were noted in the cells. He has had a several-month history of vague upper quadrant pain, left upper quadrant pain, and early satiety. Which of the following is the most likely finding here? Okay, what do you guys think is the diagnosis? The probable diagnosis here should be in hairy cell leukemia, right? Okay, with all the we have pancytopenia and vague left upper quadrant pain signifies an splenomegaly, a spleen which is dragging there, hairy cell leukemia, right? And of the options, will hairy cell leukemia have an hypercellular bone marrow? Definitely no, right? Hairy cell leukemia has pancytopenia and myelofibrosis. So the hypercellular bone marrow with more than 20% myeloblast would fit into an AML, right? So option A is wrong. Second option says dysplasia involving all lineages. And I'm going to have dysplasia involving all lineages. Which hematological malignancy will have that finding? Most likely an MDS, though I cannot categorize it with this information alone. Dysplasia, most likely an MDS, or it could be an MDS with AML or something of that sort. Fine, definitely not a hairy cell leukemia again. And hypercellular marrow with severe decrease in megakaryocytes only. Right. So I'm going to have a hypercellular marrow and only megs are reduced. There are more congenital conditions where I have amegakaryocytic thrombocytopenia. It could be that, or something related to macrocyte destruction problem alone, right? So it's not again hairy cell leukemia. Like you guys said, that the only option which fits for a hairy cell leukemia diagnosis here is a right tap on the bone marrow biopsy, right? It should be on a bone marrow biopsy, not an aspirate, right? Okay, it should be actually be an aspirate, not a biopsy. It should be a bone marrow aspirate. You'll have a right tap biopsy. You'll have the finding of myelofibrosis and everything. The hairy cell leukemia is one of my favorite neoplasms because the pathogenesis plays a very, very key role. I just want you guys to listen, and if possible, imagine to the best extent possible. Download all your thoughts of imagination because hairy cell leukemia is a very, very interesting pathogenesis. we have an heritage leukemia, first tell me what do you think is the cell of origin? We have pre-germinal center, germinal center, and post-germinal center. Though we don't discuss that for heritage leukemia, I want to discuss in depth for only one marker. Heritage leukemia comes from your memory B cells, the activated memory B cells. So it's in post-germinal center neoplasm. Fine. So I'm sure you guys know what is the mutation you're going to see in heritage leukemia. The mutation which is commonest mutation seen in heritage leukemia is your BRAF V600E, right? So BRAF V600E is the main pathogenesis in case of an heritage leukemia. That drives almost every finding what I'm going to see in heritage leukemia, right? So BRAF V600E is a proto-oncogene. So I'm going to have a mutation. There's going to be a gain of function mutation, which causes the proliferation. That we'll keep that one side, right? It causes proliferation. So there are few other things my BRAF mutation does. One of the main thing is it's going to activate a protein called as GAS7, growth arrest specific molecule, GAS. That it's going to do, it's going to activate my G-actin, the globular actin, to become F-actin. That's your filamentous actin. That's the second thing it's going to do, right? So I'm going to have a cell with actin filaments. It's not the globular actin. So these actin filaments are going to go and hit my cytoplasmic membrane. When it hits my cytoplasmic membrane, what it does is it's going to kind of produce a projection. So it look like a hairy cell. And that's the primary appearance here. So I'm having a cell, any cell, let's remember any cell. When I'm having that just now we saw it's a post-germinal center B cell, right? In a post-germinal center B cell, it's going to kick like slightly indent my cell membrane, the projection. So what is there surrounding any cell in a lymph node? Any cell in a tissue is obviously surrounded by extracellular matrix, right? I'll have extracellular matrix undoubtedly in every cell. Except for blood, in every tissue organ, I'm going to have extracellular matrix. So this extracellular matrix is the one which is going to respond to any injury. When a cell dies, I have to have your healing by macrophage. So the stroma, everything is by my extracellular matrix only. So this extracellular matrix is going to be stimulated because of this destruction or because of the F-actin. So what it does is this F-actin goes and pokes my extracellular matrix. Once my extracellular matrix is poked, the first person to get stimulated is integrin, because integrin is one person which connects my cell to the extracellular matrix, first person. So this integrin goes and kicks my extracellular matrix. Once it kicks my extracellular matrix will have fibroblast growth factor, transforming growth factor beta, that will get stimulated also, right? So this F-actin is going to stimulate all these guys. Keep this in memory. We'll just come back to it soon. So I'm having a cell with a projection. The F-actin is going to destroy this. The same thing, the BRAF mutation also does one more thing. It inactivates ATP and GTP. The mutation activates a Rho protein. It's a molecule, Rho family of GTPases, that will be activated. So once GTP is activated, my GTP is going to get destroyed. So once GTP gets destroyed, I'm going to have most of the energy dependent mechanism in the cell. It's going to be lost because I don't have an GTP or an ATP. So when I don't have an ATP or a GTP, one of the most important energy dependent mechanism is your phosphatidylserine, which is going to be on the inner aspect of the cell membrane. So once energy is gone, this phosphatidylserine comes on the outer aspect of the cell membrane. We have read the same thing in one more pathogenesis. What is that? I'm sure you guys know it's apoptosis, right? In apoptosis also, we saw the same thing. The phosphatidylserine comes on the outer aspect. Once it comes on the outer aspect, it's just apoptotic signal, right? So, and these cells keep roaming around all throughout the body, especially spleen. When it goes into the spleen, who will eat them? I'm having phosphatidylserine, which is going to be a signal for my macrophage. And spleen is definitely filled with macrophage, right? So the macrophage is going to consume them, eat them. So when I say the macrophage is going to eat them, I've discussed this already. We'll go a little bit in more depth. I'm having a B cell, which is getting destroyed. So it's my macrophage is eating this B cell. So I'm right in saying that it kind of looks like an autoimmune process, where the self-cell destruction, though it's a neoplastic cell, it's my self-cell, it's getting destroyed. Neoplasm escapes by saying I'm my own self-cell, right? So the self-cell is getting destroyed, so it's like an autoimmune reaction, right? So I'm having autoimmune-like reaction in a peripheral cell. So when I'm having peripheral cell autoimmune-like reaction, am I right in saying that you must have learned in immunity some process called as an peripheral tolerance? Do you remember T regulatory cells in them? If you remember T regulatory cells will have few certain molecules which are specific only for them, FOXP3 and CD25. So what these B cells does is, I want to avoid from cell death. The survival instinct is definitely much more sure for every cell in my body. So this B cell kind of kicks on your CD25 and makes it express on the surface so that I'm not going to get killed. So I'm going to tell to my macrophage, don't eat me. Though I have phosphatidylserine, I am your self cell. Please don't destroy me. So only few cells escape. Those few cells escape will have CD25 as a marker. Is that a marker for hairy cell leukemia? It is a marker for hairy cell leukemia, right? So I'll have that one in one part. So let's assume that these cells keeps roaming all over the body and it goes to my bone marrow. In the bone marrow also the same process happens. The filamentous actin is going to kick my bone marrow stroma. And bone marrow stroma, once it's kicked, it will produce your TGF beta, FGF beta. So what it will cause? It will definitely cause you myelofibrosis as well. So I'm right in saying that all these are macrophages which are being consumed, right? Macrophage is going to eat all of them. So my spleen has already taken care of its full potential. My spleen requires more macrophages here. So when my spleen requires more macrophages, the immediate person I can recruit from my bone marrow, my blood is my monocyte. It's going to recruit more and more monocytes in order to help me to eat more and more neoplastic cell, which BRAF is giving me. Because the mutation is permanent, it's going to keep on giving lots and lots of neoplastic cells. So monocytes will be recruited by my blood cells. So I'll have monocytopenia as well, right? So now we'll compile everything. When you see a patient with hairy cell leukemia, age is immaterial. It's like any other neoplasm, 50 plus age group first finding. I'm going to have massive splenomegaly. That's one of the findings because all these processes happens in spleen. It's going to get destroyed. Hairy cell leukemia also has down regulations of few specific chemokines. So lymph node will not be involved. Though it's a post-germinal center B cell, lymphadenopathy will not be seen in hairy cell leukemia because of few down regulations of chemokines, which are also given by my BRAF, right? So there'll be no lymphadenopathy. So I know that I'll have pancytopenia because of my myelofibrosis. I'll have monocytopenia because all the monocytes went again to my macrophage to help the macrophage, right? So everything fits inside. Pancytopenia, a dry tap, a monocytopenia. Because of monocytopenia, there'll be an opportunistic infection. Monocytes are very, very essential for your tuberculosis and mycobacterium, atypical mycobacteria. So those opportunistic infections will come inside because there are no monocytes here. In addition to that, now we'll come to our IHC markers. Our main problem is an IHC marker, right? It's a B cell. So they are definitely 1920 positive. PAX5 will be positive. It's also a B cell marker. There are two markers which are very, very important for me. One is annexin. So annexin is very important marker to differentiate from all the B cell neoplasms. So when I have phosphatidylserine expression, I am right in saying phosphatidylserine expressed. Annexin is a marker of apoptosis also. Annexin actually binds to the phosphatidylserine. So all these things which are expressing phosphatidylserine, when I do annexin, it will be positive. So only the tumor cells will be positive. One more marker. The second specific marker is DBA44. DBA44 is a marker for post-germinal center B cell. So it explains my origin as well. Post-germinal center memory B cell will have DBA44. From that, this neoplasm comes. So I'm going to have hairy cell leukemia as the only neoplasm which has this. Maltoma will not have this because hairy cell leukemia is an activated memory B cell. Maltoma does not come from my activated memory B cell. That's again one. The next one is CD25. When I say CD25 just now we explained that why we are going to have it. Because CD25, my B cells are getting killed. So I express CD25. I react like my T regulatory cells, trying to suppress my autoimmune response via peripheral tolerance. So CD25 comes there. I'm sure you'll know one more marker as well. Do you remember a marker which is CD11C? You remember CD11C? I'm sure you'll remember CD11C. Let's go back to general pathology again. You must have read this again, CD11B bar CD18. Where did you read that? CD11B bar CD18 will be mutated in which condition? You know the answer. I just want you to say the answer. CD11B bar CD18. You must have read that in your leukocyte adhesion deficiencies. So CD11, the entire group of CD11 is integrin markers. A, B, and C are just the subtypes, right? So CD11C with their express means I'm going to have integrin expression. We just now read, right? So when I have a filamentous F actin, that's going to poke my integrin because integrin is a connect between my cell and the extracellular matrix. So that also will be overexpressed here. It will be activated here, right? So integrin marker also will be there. So I'm not going with CD11C, though it's a good marker. I'm not going with CD25, though it's a good marker. I'm going with annexin because the primary pathogenesis plus DBA44 because of the origin. TRAP is also an enzyme which we're using these days with annexin and DBA44 coming into place. The role of tartrate resistant acid phosphatase is reducing a lot, right? Hopefully in future we'll not use TRAP. TRAP was used previously. Now the utility of TRAP has become less, though it's a good marker. I'm not saying it's a bad marker. It's a cytochemistry marker. I can do it on a blood, not on a biopsy. So generally, if we take a bone marrow biopsy, I'll look for annexin or a DBA44, right? So this combines everything about an hairy cell leukemia. Just if all these are true, am I right also in saying that the tumor burden will be less? Because most of the cancer cells are being taken care of by my body's own macrophage. If the tumor burden is less, prognosis is good or bad? It should have a good prognosis, right? I'll leave the prognosis and treatment part to Dilip. Dilip will continue it from here. Okay. If you have any doubts in the pathogenesis, do let me know.
I think this is a slide that you have it, right?
Yeah. These are the Harry projections. You can. It's a spotter. Once you see a Harry cell leukemia, you'll never ever forget it. Okay. So just an Harry cell leukemia. These Harry projections will not be seen on a bone marrow biopsy because they are very, very flimsy. So in a bone marrow biopsy, all these projections will be seen clear. So it's called as a fried egg appearance. The next slide shows that you'll have a perfect fried egg appearance there. You can see that it's blue is nothing but the nucleus. Surrounding every nucleus, you will have an halo. We assume that there are hairy projections there which are not seen in a biopsy. So you'll have your classical fried egg appearance, fine? Dilip.
Okay. Hairy cell leukemia is something that is not so common, but we still do see in tertiary care centers at least maybe 1 or 2 cases per year. Hopefully, and maybe in hematological centers, the turnover may be even more higher. But if it's treated properly, and if you identify early and if you treat this properly, this has a very good prognosis. In fact, we have seen patients with years, not years, even decades of remission. So I do have like a couple of cases who had an ex-hairy cell leukemia, like maybe 5-6 years ago. They've been presented with hairy cell leukemia, treated properly, went for remission, and still now absolutely have no problem. He got COVID, didn't have any issues. Then he had lobar pneumonia, he didn't have any issues. But most of the problems that a patient with hairy cell leukemia is going to face is due to infections rather than the leukemia itself. Like what Ranjith said, it's mostly going to be due to infection. So that's what we need to be wary of. And whenever you see hairy cells, of course, it doesn't mean that it's only hairy cell leukemia, because in the peripheral smear there are quite a few conditions which can show hairy cells. First one, as a physician, what I remember is the hairy cell leukemia, and we have another one that is called as hairy cell leukemia variant. That's HCLV. This is one of the upcoming stuff again. That HCL variant, even though it is not common. HCL itself is not that common, and HCL variant is even more rarer. But previously, it's believed that it's one of the variant of hairy cell leukemia. But right now, it's very clear that it's a separate neoplasm and doesn't come under your hairy cell leukemia. The reason, because the treatment for hairy cell leukemia, as we all know, is going to be your cladribine, pentostatin, and older treatment is interferons, but typically we use cladribine, pentostatin, and vemurafenib, rituximab. So depending on what is the situation of the particular patient, what is the treatment status, relapse or remission, we are going to use one of these 4 drugs. That's what the treatment of hairy cell leukemia is. But the problem with the hairy cell leukemia variant is the fact that it does not respond to your traditional treatment properly, and they do have a poor prognosis. Like I said, hairy cell leukemia classic type does have a good prognosis, but variant hairy cell leukemia does not really have that good prognosis. So that's why it should be considered as well. And the third one is your splenic marginal zone lymphoma. I think in our revision sessions, I think in Unacademy revision sessions, I've showed you multiple images on splenic marginal zone lymphoma. One image in that will be showing the hairy kind of a cell. So this is another differential diagnosis for the presence of hairy cells. I think maybe Dr. Ranjith in his pathology classes will be explaining more about the different hairy cells.
Hairy cell leukemia variant, the first difference in diagnosis, leukocytosis. Hairy cell leukemia variant that almost always presents is leukocytosis. Here, hairy cell leukemia classical one will have your pancytopenia. Hairy cell leukemia variant, like what Dilip said, it's kind of, we are pushing it towards your pro-lymphocytic leukemia, CLL, the worst case of CLL. Some of them have hairy projections. And splenic marginal zone lymphoma, the classical projections of splenic marginal zone lymphoma will be polar. It will have exactly polar projections. Whereas hairy cell leukemia, it will be all throughout. That will be a differential diagnosis. I don't have the image. We'll share it later on. That will be one difference from the microscopic perspective of splenic marginal zone lymphoma. Right?
Okay. Now let us move on to a question. I think students will be able to answer this pretty easily. So the question asks that a 72-year-old man referred for evaluation of fatigue and physical examination appears pale and has palpable cervical lymphadenopathy as well as splenomegaly. And you can see the WBC count is pretty high. It's 35,000. I think it's not working here. So it's 35,000 here, right? With a hemoglobin of 5.6 and platelet count is low as well. Patient is having splenomegaly. And review of the peripheral blood smear shows predominance of WBCs with pale blue cytoplasm, prominent nuclei, and serrated hair-like projections. Which one of the following is the most appropriate step in the management of this particular patient? As you can see here in this particular image, you can see a lot of cells with hairy projections, is what you see here. So if it's the case of hairy projections, then you might think that it's a hairy cell leukemia, but what is the next step that you're going to do? So you're going to inform him that it's hairy cell leukemia, or you're going to initiate therapy with cladribine, or you're going to perform a bone marrow aspiration biopsy, or you're going to refer him to a tertiary medical center. Okay, somebody is telling, like Dr. Warlocks is telling, that it's a hairy cell leukemia variant. So you can't really confirm that it's a hairy cell leukemia variant at this point of time. It could be anything. So don't you think, like no other neoplasm comes with a picture like this? It could be the case. I mean, even though Dr. Ranjith said that WBC count is going to be low in patients with original hairy cell leukemia, and it's going to be high in patients with variant, but you cannot differentiate 100%. So still you need to go for bone marrow aspiration biopsy to go for IHC and other markers, and you need to find out so what's going on. So ideally the option is going to be C. Okay, so you can't inform that this patient is having hairy cell leukemia. You can't initiate therapy with cladribine unless until you are very clear about your IHC diagnosis. And straight away, I don't think it's better. I mean, it's time right now to refer to a hematological center because you don't have the diagnosis. So better diagnose and then you refer to a hematological center. And when you come here, the next question, the patient described before undergoes diagnostic testing, bone marrow biopsy reveals the following: 80% involvement of monoclonal population of B lymphocytes, well and good, with a fried egg appearance, as Dr. Ranjith said some time ago, expressing CD20. Of course, it's a B cell, so it's CD20 and CD11C positivity, and CD103 positive and CD123 positive. But the most important things here is the BRAF V600E mutation testing is negative. So that's the most important thing here. And apart from that, this patient is showing a mutation of MAP2K1, and computer tomography scans of the neck, chest, and abdomen shows prominent generalized lymphadenopathy, which is something that you need to note. And apart from that, he has hepatosplenomegaly as well. So, which of the following is false? So, treatment with cladribine and pentostatin assay with a good prognosis. 50% of the patients may be assayed with MAP2K1 mutation, and trap stain would be negative, and splenic biopsy would show infiltration of the red bulb. So, what do you think is the right answer here? Okay, so there are two wrong statements here, which becomes the right answer. The first one is trap stain would be negative. That's definitely like a right answer. We are asking about which is false here. Okay, so this is the right answer. So usually in a hairy cell leukemia variant, it is supposed to be negative. It usually won't be positive. I'll come back to that in a while, because this patient is having not a hairy cell leukemia. This patient is having a hairy cell leukemia variant. Okay, this is not a typical HCL. It's a HCLV. So why it is a hairy cell leukemia variant? First of all, you need to know that this patient is having negative BRAF V600 mutation, which is one of the signatures of the classic hairy cell leukemia, even though not in 100% cases, but still it's one of the signature mutations of your classic HCL. So that is negative. So I'm not going to think really of the classic hairy cell leukemia variety. And second, this patient is having a lymphadenopathy that strongly goes against your diagnosis, because usually a classic hairy cell leukemia, as we discussed already, will not be coming with significant lymphadenopathy. And at the same time, the markers did not say anything about CD25. So that's very important. Usually CD25, if they are not mentioned, because if that is not mentioned, which means you can take it for granted it's negative. So CD25 is negative, it's not mentioned. So usually a classic hairy cell leukemia will be having a positive CD25, as we discussed already. And next, as Dr. Ranjith said, annexin A1, very important. So annexin A1 usually tends to be negative here because it's not mentioned. I can take it for granted it's negative. So, but the most important clues are going to be this lymphadenopathy. The patient is having leukocytosis. Patient is having negative BRAF V600 mutation. There's no mention on CD25. There's no mention on annexin A1. So there are a lot of things that goes against the diagnosis of classic hairy cell leukemia. So I would likely to make a diagnosis of a hairy cell leukemia variant. So first of all, the trap stain would be negative is a very correct answer. There's no doubt about that. And definitely 50% is associated with MAP2K1 mutation is definitely correct. So as I told you, the question itself says that the patient is having a MAP2K1 mutation. So perfect. And splenic biopsy would show infiltration of the red pulp. Yes, any hairy cell leukemia is going to cause infiltration of the red pulp only and not the white pulp. The classic other condition, though, which we have been discussing, the splenic marginal zone lymphoma, is going to have infiltration of the white pulp. So, but the hairy cell leukemias, both the variant as well as the classic variety, is going to have infiltration of the red pulp only. And as I told you multiple times at the beginning of this session itself, treatment with cladribine and pentostatin is with a good prognosis. It's wrong. This is the right statement because this statement is false. So if you want to say this is the wrong statement, so the question is asking which of the following is false. So that's the answer here. The answer is A for this question. TRAP would be negative, correct. Splenic biopsy will show infiltration of the red pulp, correct. And 50% is associated with MAP2K1 mutation, correct. But as we told in the beginning, the variant hairy cell leukemia does not really respond to your treatment. And it does have a reasonably bad prognosis to document for. Anyways, so how will you differentiate hairy cell leukemia and hairy cell leukemia variant? Okay, the details, I think Dr. Ranjith is the best person to tell the details, but at least first look at the total count. Total count is usually going to be low in a classic variety, but generally it's supposed to be high in a patient with hairy cell leukemia variant. And look for the lymphadenopathy. Usually it will not be very conspicuous in patients with classic type, but usually it will be the case in patients with variant hairy cell leukemia. And you know that you're going to have a dry tap for hairy cell leukemia, but here you don't get that classic dry tap in patients with variant hairy cell leukemia. In fact, you encounter very easy aspiration here. And as far as TRAP is concerned, usually it will be positive in patients with hairy cell leukemia, whereas TRAP will be negative in patients with variant hairy cell leukemia. And your annexin A1 very likely to be positive for your classic hairy cell leukemia, but negative for patients with variant hairy cell leukemia. And maybe if you want to say some other, I don't have the space here. So if you want to say some other points, maybe I can say that your hairy cell leukemia will be having the BRAF V600 mutation positive, but you don't get this in patients with hairy cell leukemia variant. And usually, if you want to be even very clear, then the CD25 will be usually differentiatable. So usually CD25 will be positive for a classic hairy cell leukemia, whereas CD25 will be typically negative in patients with the variant hairy cell leukemia. But one important thing that you need to know here is both could be CD103 positive. So it doesn't mean that if CD103 is positive, it is a classic hairy cell leukemia. And patients may have a splenomegaly. So, I mean, both the classic variety and the variant hairy cell leukemia can have splenomegaly, in fact, a significant splenomegaly. And both of these patients can have hairy cells, that is cytoplasmic projections in the peripheral smear. So they can have hairy cells in the peripheral smear. So probably I told you the common points here, and I've told you the differentiating points as well. And many students will be, are asking what is the treatment for the variant type of hairy cell leukemia. As such, currently we don't have any well-defined treatment because of the rarity of this disease. It's not so common. Plus, at the same time, we tend to treat with the same treatment as what we do for the classic hairy cell leukemia. But the problem is it doesn't respond properly, and as such, we don't know exactly what treatment to give. And we use the same cladribine, pentostatin, rituximab, vemurafenib, but vemurafenib should not be used here because BRAF V600 is negative, but we're going to use similar treatment line apart from vemurafenib for hairy cell leukemia variant also, but it doesn't really respond well like what you really see in patients with classic hairy cell leukemia. And the remission rates are much poorer, and the relapse rates are much higher, and the overall survival is actually quite less in patients with variant. So this is something you need to know. And apart from that, as I've told you, there is another cancer that can also show hairy cells, that is splenic marginal zone lymphoma, which can also definitely show hairy cells. But what I'm asking is, there is one important difference, I guess. I think in our image-based discussion session, I showed you this image, the splenic marginal zone lymphoma, the specific type of cells. I think many of the students who are attending the session right now, especially Sayantan is attending, I guess. So many of the students who are attending right now are, these are supposed to know this, like, because I've shown that. So shown that type of cells that you see in patients with splenic marginal zone lymphoma. So what do you see there? Any idea? I've shown the image specifically. I'm very sure about that. In fact, 2 to 3 times I've shown that. Okay, if you have not attended the session, then I would like to tell that the type of lymphocytes you see are called as villus lymphocytes, which does have those kind of cytoplasmic projections. But here, typically, you have this kind of polar projections, in the sense that you won't have this kind of uniform cytoplasmic projections that you see here, kind of uniform cytoplasmic projections here. But in patients with splenic marginal zone lymphoma, you're going to see more of your polar projections. That's very characteristic of a splenic marginal zone lymphoma. And apart from that, the markers are a little different. And I think Dr. Ranjith will be the best one to tell about these markers. And what are the markers that are going to be there for splenic marginal zone lymphoma? The presentation is also going to be pretty different. And the age group of presentation is going to be the same for all. And your pancytopenia is not a feature of your splenic marginal zone lymphoma as well. And the classic hairy cell leukemia is going to be more common in males, but whereas your variant and splenic marginal zone lymphoma, there is typically no sex predilection as such. And I told you the bone marrow will have an easy aspiration, and you don't really have a dry tap like a classic hairy cell leukemia. And annexin A1 will be negative for splenic marginal zone lymphoma. TRAP will be negative for splenic marginal zone lymphoma. And your BRAF V600 mutation will also be negative for a splenic marginal zone lymphoma. And that's all, I think so. And many of the markers can be confusing, but your other picture will definitely tell you that it's a splenic marginal zone lymphoma. It's a kind of a different diagnosis. And if you do a splenic biopsy, you're going to see the infiltration of the white pulp, maybe plus or minus the red pulp, but white pulp infiltration is going to be prominent. So you have multiple ways to diagnose splenic marginal zone lymphoma, even through IHC. We're not going to discuss. That's a topic for another day for now. Okay, now I think this is a kind of a cell I want to show you. So I think this is the same diagram I've shown you in the image-based discussion classes, kind of a polar cytoplasmic projection that you see here. So these are actually the villus lymphocytes that you see in patients with splenic marginal zone lymphoma. Okay, so now coming to the treatment part. So are you going to treat all the patients, or you have any specific indications for treatment? So if the moment you diagnose a hairy cell leukemia, you're going to treat, or you're going to have any specific indications? What's your take? If so, if you say like specific indications, you need to say what indications for therapy. Okay. So if you're not saying, let me say, you're not going to treat all the patients with hairy cell leukemia. In fact, you can observe if it's a classic hairy cell leukemia. I'm not talking about the variant. If it's a classic hairy cell leukemia, definitely you can wait and watch to a lot of extent. And we have some indications for therapy. And the first indication for therapy is significant cytopenias, of course, because whether the leukemia kills the patient or not doesn't matter. The cytopenias are going to kill. As I told you, the infections are going to be the most important problem in this patient. So cytopenias, if it's significant, definitely you need to treat. So when you require cytopenias to be significant, if your absolute neutrophil count is less than 1,000, so maybe moderate to severe neutropenia. Remember, ANC less than 500 is the one you called as severe neutropenia, but less than 1,000 is moderate kind of neutropenia. If it's the case, then probably you can consider treating. And if the hemoglobin is less than 11, so most of the patients will be having hemoglobin less than 11, but still this becomes an indication for treatment. Or if there is a significant thrombocytopenia, like platelet count less than 1 lakh. So these are cytopenias we expect. So, and if any one of this is there, then definitely that becomes an indication for treatment. And second, of course, if the patient is having a symptomatic splenomegaly. So many people, because of the massive splenomegaly, they might feel that kind of a dragging pain or pull or push. Even we have seen patients who don't get adequate sleep because they cannot turn to one side. So they will comfortable when they turn to the left side. When they turn to the right side, the spleen drags and it causes a bit of a pain and discomfort so that they can't sleep properly. So if it's very symptomatic and affecting the quality of life of the patient, then probably you can consider treatment. Or the patient is having B symptoms, or probably rather than writing B symptoms, I can call it as constitutional symptoms. The night sweats, fatigue, weight loss, fever. If it is significant enough, then that becomes an indication for treatment. So usually these are the indications for treatment. And what is the treatment option that you have? Of course, we are going to use purine analog-based therapy. The first line treatment option that we prefer giving is cladribine, of course. And pentostatin is the second option. We don't really prefer, but cladribine is a very good option. So the first option is always cladribine. It's a purine analog, we know that. And the dose and the duration is beyond the scope of the current discussion. But anyways, the cladribine is the first line therapy. And patients who don't respond to cladribine, maybe suppose if they go for recurrence, or we call it as relapse, or if the patient is going to go for refractory disease. If the disease is either refractory or the patient who responded initially, now if they're getting a relapse, then you can go for some alternative therapies. Alternative therapies in the sense, very commonly we prefer giving a combination of vemurafenib and rituximab. So you know why we give vemurafenib? Because this is a BRAF inhibitor, and classic hairy cell leukemia shows significant positivity for BRAF V600E. In fact, one of the classic mutations in, classic hairy cell leukemia. And you know, BRAF mutations are something that can be seen in many other situations, not just your hairy cell leukemia. And one more important tumor everyone knows, melanoma, shows a lot of 50% of melanomas does show the BRAF mutations, and as does your hairy cell leukemia. So it's not a specific mutation, but still, since majority of them do have positivity for BRAF V600E, we're going to give vemurafenib. And of course, rituximab can be tried because this tumor is strongly CD20 positive, because it's coming from the B cells, post-germinal center. So rituximab can be tried. So this is for relapsed disease. And this therapy was experimental, I think, till last year, maybe Jan 2021 only. I think the phase 3 came up, and I think this got approved by April or May. I'm not very sure. So maybe around April or May it got approved. This therapy is now like evidence-based. You can do it because it's on the textbooks now. So maybe not on the textbooks, but it will come in the textbooks in the next editions probably. So probably this is a treatment. So this is what I want to say. Probably for undergraduate level, this must be more than enough. Okay. I think anything else you want to add upon, Ranjith?
Okay, only one thing. Whatever we read in hairy cell leukemia variant, we were seeing more of negative markers, right? We were not going into positive markers. One thing which will be intensely positive is immunoglobulin. The surface immunoglobulin will be very much positive in a hairy cell leukemia variant, okay, and not in classical hairy cell leukemia. That's one thing. And then the second one is your immunoglobulin heavy chain. That translocation is more common in hairy cell leukemia variant. If the immunoglobulin heavy chain translocation is not there, and if P53 mutation is there, it makes the prognosis much more worse, right? That's one. And then when coming to splenic marginal zone lymphoma, the IHC wise for splenic marginal zone lymphoma, it's like a routine maltoma, except for one marker, CD24. CD24 is a marker which is positive in splenic marginal zone lymphoma alone. Fine. Those are the only few things I want to add. It's called a splenic lymphoma with villous lymphocytes. So the name itself goes with villous lymphocytes, so that's diagnostic. And if you see a villous lymphocytes, that's definitely going to help you in that diagnosis, right?
Okay.
Okay, that's all. That's all.
I think hairy cell leukemia, I think cladribine, as simple as that. I think that must be more than enough. You need not know anything else. That's the treatment. Okay. Now coming to this question, I think Ranjith will take over on this particular question.
Be able to finish at 8:50.
8:50, maybe 10-15 minutes. I think we'll be able to do that.
Okay, 70-year-old man with a history of hypertension, diabetes presents to the clinic with 10 kg weight loss in the last 7 months, which is definitely a significant weight loss. Okay, 70-year-old person hopefully will not be more than 100 kg. So considering that it's 10% in 6 months, so definitely a significant weight loss. The patient has extreme fatigue, arthralgia. CBC as a basal metabolic panel shows normal sodium, potassium. Your BUN is 70, creatinine is 9.5, definitely a renal failure. CT scan shows diffuse enlargement of both kidneys. The enlargement is one of the important findings here, coming for arriving to the diagnosis. Okay, And the biopsy shows an lymphocytic infiltrate, plasma cells, storiform fibrosis, obliterative phlebitis, and variable amount of eosinophils. Eosinophils can be seen in these pathogens as well, right? Which of the following is the next test you will do most appropriately considering this disorder, right? I'm sure all of you must have come to the perfect diagnosis here. You're talking about an IgG4 mediated disorder. That's why I said that CT scan increase in size is one of the deciding criteria for IgG4 mediated disorder. Plus, I need your serum IgG4 level, clinical, as well as your microscopic. Since I don't have the IHC for IgG4, with a serum IgG4 levels elevated and also clinical feature, we can go for a definitive diagnosis of IgG4 rather than calling it probable or possible. As a reason, we require that if your IgG4 IHC is available, that should be more than enough for your diagnosis as well. Fine. It's a classical case of IgG4 mediated disorder. Couple of years back, JIBMA asked a question on IgG4 mediated disorder. After that, no one, JIBMA or PGI Chandigarh. After that, there's not much of question there, though it draws lots and lots of attention for the clinicians, for pathologists as well. Whenever there's plasma cell, we get excited to push it towards IgG4 mediated disorder. It's more of an a trending thing in pathology, like, because whenever something trends, we try to push it, we try to reclassify everything, because whenever we call something a fibrotic lesion, it's end stage. There's no use in giving a diagnosis fibrosis, because once fibrosis is done, it's not going to be useful for the treating physician, not for the patient. It's gone. So when I say a fibrosis and when I put it into IgG4, I give a hope that it's possible to treat, because I know the pathogen is a little bit. And that's a hope, hoping that Dilip will say whether it's treatable or not, hoping that since a plasma cell mediated disorder, hope if it's not completely fibrotic, maybe we can stop the lesion and we can make sure the fibrosis doesn't progress anymore. Only that reason we're going to look for it. You guys know the diagnostic criteria is clinical, serological, histopathological. Every organ involved by IgG4 mediated disorder should have an increase in size. That's one of the predominant important criteria. A diffuse or localized swelling can be if it's thyroid, entire lobe of thyroid enlarged also, I'm going to think of it. One lobe of thyroid enlargement, it should be enlarged. It should not be atrophic. It should be enlarged. That's one criteria. And organ dysfunction should be there. Here it shows the creatinine is definitely elevated. Your urea is elevated, definitely organ dysfunction. Your serum IgG4 level should be greater than 135 milligram per deciliter. And the three criteria where it is done, storiform. So storiform means it's like a wheel, right? This image which shows the second image, the B1, that's from an article from NAGM. The second image which shows that the black ones are the fibers and the white arrow marks, which are nothing but your lymphoplasma. Though it's in low power image, it's in blue cells. That's all. Storiform is it should be like radiating. Best example for storiform is when you have a cartwheel and it's going very fast. The spokes of the wheel will look like bent. That appearance is your storiform appearance. That's one of the important criteria. Then lymphoplasma that you can infiltrate. Eosinophils can be seen. I should not see neutrophils. If neutrophils is there, it goes against the diagnosis of an IgG4 mediated disorder. I'll think twice, especially why it's important is when you have an autoimmune pancreatitis, there are two types. One is IgG4 mediated, other one is not IgG4 mediated. The non-IgG4 mediated autoimmune pancreatitis will involve Th17 pathway and it will have neutrophils. So I should not have neutrophils in the microscopy to diagnose an IgG4 mediated disorder. That's against the rule, right? Eosinophils accepted. Your macrophages definitely accepted. Neutrophils should not be there in case of an IgG4 mediated disorder. And the fourth picture, the D picture, shows a vessel. It's the arrow marks is nothing but showing that it's the lumen is being obliterated, right? The obliterative phlebitis, and obviously the vessel wall has lots of blue dots, which is equal to WBC. It's phlebitis with obliteration of the thing. That's also diagnostic. The image shows the IHC, the C option. We should grade IHC. We can't grade IHC in this image, right? You should have an IgG4 is to IgG ratio greater than 4%, 0.4%, which means 40% of the entire IgG is made of IgG4. That's not the routine criteria. IgG4 is little, not 40%. If it's 40% or more, I think it's IgG4 mediated. Or I should have greater than 10 IgG4 positive cells in a single high power field. If we have that, it's diagnosed. Why we have two criteria? One is it can be concentrated sometimes. It not be there everywhere. One field more than 10 cells, I'm okay with calling an IgG4. Or overall, if the ratio is skewed more than 40%, I'll call it IgG4. Fine. Diagnostic thing, that should be the thing. With criteria, we can give a definitive diagnosis, probable diagnosis, possible diagnosis with different permutation combination of clinical, serological, and histopathological criteria. Fine. I'll leave it to treatment since we're running short of time. I think it'll be good if he finishes the treatment as well. What do you think?
Yeah. So I think Ranjit, you have a class at 9.
10.
Okay, fine. No problem. So I'll just take a couple of minutes here. So first of all, this patient is having a burn of 70, and as you can see, the creatinine is 9.5. First of all, they might not give you a kind of, I would say this is like a kind of a banana question. That's what I would say, because this is so easy to answer. Because the like question itself says the characteristic presentation, so I don't really think examiner is going to ask. I mean, we have designed this question just to make you guys answer, but the examiner is not going to give this kind of straightforward questions. But anyway, going towards this bun and creatinine ratio, so what do you think the patient is having? Is having a pre-renal AK or an intrinsic renal AK or probably a post-renal AK? So what do you think? What do you think, by the way? Okay, so first take the bun creatinine ratio and see. So I think it's somewhere around 70/9.5. I think definitely it is less than 15. So whenever the bun creatinine ratio is less than 15, it must be either an intrinsic renal disease, or even it could be a post-renal disease. Both are possible, okay? So bun creatinine ratio is more than 20 means it is very likely a pre-renal disease, but bun creatinine ratio less than 15 could be an intrinsic or post-renal disease. But the patient also has kind of, like in the CT, you don't see any hydronephrosis or you don't see any obstruction in the ureters, which clearly says that this patient is a kind of having intrinsic renal disease and not a post-renal disease. And especially when it comes to IgG4 related disease, both are important, because IgG4 related disease, do you think it can cause only intrinsic renal disease or it can cause post-renal disease also? What's your take? IgG4 disease will result in intrinsic renal disease only, or it can cause post-renal disease or probably pre-renal disease. What is your take? Remember, IgG4 related disease can produce multiple effects. So when it comes to the kidney, it can produce intrinsic renal, and it can produce post-renal disease also. So how is it possible? I mean, if you tell that if both are possible, then you have to say how it can produce both. So first, intrinsic renal means what is the disease that is caused by IgG4 related disease, and post-renal means what is the disease that you expect in this situation. So what will result in post-renal AK and what will result in intrinsic renal AK? Remember, IgG4 related disease, if it directly involves the kidney, it can cause acute interstitial nephritis, AAN. Because of that, it can cause intrinsic renal disease. And on the other hand, if it's going to cause retroperitoneal fibrosis, it can result in post-renal disease also. So that's why it's very important to know. So that's why we do the CT. So where is the problem? The problem is the bulky kidneys, or the problem is the mass in the retroperitoneal area. So that is why you have this question. So which of the following subgroups accounted for the highest percentage of IgG4 related clustering? In the sense, what I'm asking is, currently IgG4 related disease has been clustered into 4 different categories: those that involve the head and neck structures, those that involve the hepatobiliary area, and those that involve head and neck disease, but with Mikulicz syndrome kind of a picture and systemic involvement, and those that have retroperitoneal fibrosis and or aortitis. So, what do you think the right answer is among the 4? This is a kind of data-related question, but still, I would like to ask. Okay, which is the one that's going to be the most common? So, if you want to really ask in a PG aspirant perspective, which is the most common? I think only one of you are right. Maybe current now 2 of you are right. So answer is pancreato-hepatobiliary. So this is the common. Okay, this is the one that is quite common. So most common type. In fact, 40 to 50% of the patients with IgG4 related disease will have pancreato-hepatobiliary dysfunction only. So disease. Apart from that, they can involve head and neck structures, including pituitary, where it can mimic lymphocytic hypophysitis. It can come like that, and they can come like kind of a Mikulicz syndrome, like Jogren-like picture, plus at the same time they might have systemic involvement. And head and neck includes your Riddle's thyroiditis-like picture also, fibrosing thyroiditis-like picture also, even that is possible. And of course, your retroperitoneal fibrosis and or aortitis can happen as well, which means quite a few number of cases of retroperitoneal fibrosis can be classified under IgG4 related disease. Now, IgG4 related disease is something that's going to affect each and every single area of the body. But overall, you're going to classify under these four groups only. Among these four groups, the most common is pancreatic or hepatobiliary involvement. Okay. Now coming to this one, this question. So what do you think is the right answer here? Which of the following subgroups have accounted for the highest percentage of IgG4 disease, IgG4 related disease clustering? So which means which had the, okay, same question. Okay, I think it's the same question, right? Sorry for that. Maybe I can ask the question another way because I am the one who framed that question. But anyways, so I can ask which among these four, which of the following will have the highest serum IgG4? Maximum serum IgG4. Maybe I can ask in that way. So now we know the four things among these four, which is the one that's going to have the maximum serum IgG4. Maximum serum IgG4. Okay, so I'm not getting any answers, but maybe, okay, varied answers by now, but I'll tell the answer. The answer is B for this, okay? B is the right answer. So as the thing implies, you have systemic involvement here, right? So whenever you have systemic involvement, you can imagine that serum IgG4 is going to be grossly high. So these are the group of patients who are going to have the maximum serum IgG4, and these are the group of patients who are going to have least serum IgG4. In the sense, serum IgG4 will not be elevated in all the patients. That's very important to understand. It will be roughly elevated in approximately only 60% of the patients. Remaining 40% of the patients, the serum IgG4 can be absolutely normal, so or at least relatively normal. So you cannot confirm or rule out a diagnosis based on your serum IgG4 levels. That's why, as Dr. Ranjith rightly said in the beginning, you need that clinical picture, plus at the same time you need that biopsy picture, plus you need to correlate that with serum IgG4 so that you can make a diagnosis. So remember, so this is the one that's going to have maximum serum IgG4, and this is the one that's going to have a least serum IgG4. Coming to your, because this case is all about your nephrology. So when you talk about acute interstitial nephritis, there are very few causes. In usual situation, it's always the drugs, drugs, and drugs. When you talk about drugs, only two things you need to know for exams. One is antibiotics, and second is NSAIDs. Any antibiotic, for that matters, can result in AN, but your beta lactams and sulfa are the most important. And NSA is very important. And upcoming data says that your proton pump inhibitors are also have been implicated in variety of cases of acute interstitial nephritis. And second, of course, infections pretty important as well. Number three, you can go for systemic disorders. Systemic disorders. In the systemic disorders, you can push connective tissue disorders, including systemic lupus erythematosus. But remember, the AIN caused by lupus is different from the traditional lupus nephritis that you see. So that is glomerular involvement, okay? But what you see here is kind of an interstitial involvement. That's different from the 6 classes of lupus nephritis that you see in your routine, like pathology or medicine textbooks. Then coming to other systemic disorders, the IgG4 related disease is another one, which is an upcoming one, which could result in presentation of acute interstitial nephritis. And number 3 is going to be your TINO syndrome. Okay, TINO is tubulointerstitial nephritis with uveitis. So that's very important. So in exam, if you get a recurrent anterior uveitis, along with that, if the patient presents with renal injury and acute interstitial nephritis, always think about a TINO syndrome, which is another possibility in the situation. Okay, now we are all about IgG4 related disease and treatment. As we know little about the treatment because it's a very new disease relatively, the treatment is going to be absolutely immunosuppression. That's the most important treatment. Immunosuppression means most of the time it does respond to steroids, and you can use some disease modifying drugs also like methotrexate, azathioprine. It's common policy among rheumatologists to generally start with another steroid sparing agent like methotrexate or azathioprine. That's what we do, but there is no stronger evidence for that according to the international journals. But the guidelines say that start with steroids. Suppose if the patient has a poor response to steroid, probably relapsing disease, then probably you can go for rituximab, because this disease is all about these plasma cells. So these are B cells which are becoming plasma cells. So stop them from working. So ideally, you can go for rituximab. So if the disease relapses or if it's refractory, then rituximab will be a better option. And you can, yes, try some steroid-sparing drugs like methotrexate, azathioprine, mycophenolate mofetil as well. But I believe that these two are the cornerstone for therapy as far as IgG4-related disease is concerned. Anywhere in the body, doesn't matter. So final take-home point is that your IG4 disease can, when it comes to the kidney, it can result in both intrinsic renal as well as post-renal disease by causing AN as well as retroperitoneal fibrosis. And second, among the four clusters, pancreaticobiliary is the most common, and serum IG4 is maximum in the hereditary disease with Mikulicz syndrome and least with retroperitoneal fibrosis and iotritis. And of course, treatment is going to be of immunosuppression with either steroids. Maybe later on you can switch on to rituximab or add rituximab along with steroids if you really want to have a good response. And finally, IG4 levels are not really that like reliable in making your diagnosis. Your diagnosis should have a combination of a clinical picture of a mass-like lesion and a biopsy showing that characteristic three findings, and your serum IG4 may or may not be elevated. So that's it. So I think we are good to go. It's done. Yeah. Ranjith, you want to say something?
No, it's fine. Remember the criteria. Hopefully, they won't go and dig into the criteria. At least a superficial understanding of you need all three. Plus or 1 plus 3, 1 plus 2, 1. The permutation combinations are there. That should not be asked. At least a straightforward case of IgG4, you should be able to pick it up. That should be more than enough.
Yeah, usually I think nobody has started the IG4 related disease type of question in exam as of now. Nobody has really started it, but at one point, like somebody might start, and once they have started, maybe they can go a little deeper into that questions. And I think, as Ranjit said, only one question has come in JIPMER, I guess, maybe in the past, but apart from that, nobody has really dug into this IG4 related disease. But I believe like it's in the corner, and they might be asking very soon.
Okay.
Okay.
That's it. Thank you, guys. Thank you for your patience. See you soon.
Yeah, thank you, guys. Thank you very much for your patient listening, and we hope to meet you all in another YouTube session. Thank you. Bye-bye.
Bye. Good night.
Good night.